and greetings from the Center for Infectious Diseases. So as we are all progressing towards the Antimicrobial Awareness Week, actually which falls from 18th to 24th of November, I feel the organizers, Dr. Sucharita ma'am from the Shri Academy and Dr. Kannan sir from the GBR Foundations have perfectly given me an opportunity to deliver an important topic for this day. And this year, this awareness week is to be observed by all of us with the theme of preventing antimicrobial resistance together by handling the antimicrobials with care. Since we are all from the biomedical research area and are being placed in various healthcare settings, I feel we have to take a vital role in implementing this theme, as the healthcare setting is the origin point for the emergence of various drug-resistant traits with further complications in the nosocomial infections. So that is why we have various national bodies like NABH who gives accreditation to the hospitals or labs to achieve this theme. So in the NABH body, we have actually the Infection Control Committee as the core committee or a body, with the microbiologists playing a vital role in both the antibiogram and also the AMR surveillance. But do all the healthcare professionals perform these activities on a proper note? I think it's really questionable. So I just wish to proceed my talk in 3 different phases, where in the first phase, I just want to talk about what is an antibiogram and what is the need for it towards the AMR surveillance baseline data. And in the second phase, I just want to highlight the basic guidelines that has to be followed in framing the antibiogram in all the healthcare settings. And finally, the policy based on these antibiogram pattern, how to frame the policy on the antibiotic stewardship in healthcare settings. So actually, why do we need an hospital antibiogram policy? So the World Health Organization actually points out the lack of many parameters, both by the clinician and also by the infection control professionals, where it suggests that there is normally a lack of awareness among the clinicians about the guidelines, the existing guidelines, and they are also not familiar with the guidelines. And most of the clinicians, they do not want to agree with the guidelines because they were been practicing the conventional antibiogram patterns, and they also perform whether the recent changes can be applicable, whether it could be efficacious, and again the outcome expectancy also is unsuccessful among the clinicians, and they also do lack motivations in practicing or in changing the previous practicing modes. And there are also various barriers related to the guidelines, related to the patients, and also related to the environment. So based on this, the WHO has framed the key elements of an hospital antibiotic policy to be followed for the antimicrobial surveillance data, where it starts, it tries to initiate involving a multidisciplinary groups, where the members has to adapt with the guidelines positively to form various policies to frame the recommending the antibiotic policy in healthcare settings. And periodical auditing is also involved as a key element, and the policy has to be reviewed by a review board. And finally, the proper prophylactic and empiric therapy has to be followed or has to be implemented in the form of antibiotic stewardship policy. So for this, actually the initial step in the AMR surveillance is to frame a perfect antibiogram. So as you all know, an antibiogram is a periodic summary of the antimicrobial susceptibility pattern of the organisms which has been isolated from the hospital setup, and a periodical data has to be drafted to design a proper resistant pattern leading to the understanding of the emergence on a frequent note. So for this, actually, we have to follow a standard guidelines. But I feel really very sorry to say that so many healthcare settings or so many microbiologists themselves, they are not following the proper guidelines. Actually, this is actually the CLSA guidelines, which is set by the Clinical Laboratory Standards Institute, which is used perfectly in constructing the antimyograms with the goal of promoting and reporting a reliable and a consistent antibiogram data. So this guideline has to be mandatorily followed. So in this session, I thought I can just give a glimpse on how these guidelines has to be followed in a hospital setup or in a standard bacteriology laboratory in drafting the AMR surveillance data. So normally, I do not know whether many of the healthcare professionals, whether they have turned the pages of CLSA guidelines. Actually, it is considered as a Bible for the antibiotic susceptibility pattern. And this guideline will be actually composed of so many tables with proper designations or proper numbers. And here the table 1 and table 1A and 1B is very, very vital, because these tables will give the various groups of the antimicrobial agents and the antibiotics that has to be selected for the antibiotic susceptibility patterns. So only from these tables, we have to choose each and every antibiotic according to the groups which is specified in the guidelines. And similarly, we have to immediately follow the table 2, where it indicates the standard recommended testing conditions, the QC recommendations, and about the medium, the culture conditions, the testing conditions, everything. You can just rely on these tables for to detect the MIC breakpoints for the susceptibility and the resistance data. And the third part, the table 1C and 2J, it especially concentrates on the anaerobic bacteria, which is very vital, because the MIC breakpoints for the anaerobic bacteria is really not done in various healthcare settings on a proper manner, following these guidelines. And particularly from table 3A to 3G, the resistance traits such as ESBLs, MRSA, VRE, all those resistant types of bacteria can be perfectly diagnosed or observed using the techniques which is given in these areas. So so based on these CLSA guidelines only, we have to actually perform the test for reporting the antibiogram pattern. And the CLSA guidelines actually includes different classes of antibiotics, among which few antibiotics, these dark green shades shows the bactericidal agents, and the light green shades will show you the bacteriostatic agents. So the CLSA guideline, the first table will give you the group of or the members of the antibiotics in each class, from where we have to select the antibiotic for the routine antibiotic susceptible pattern. And these antibiotics are also classified into different groups. So just like that, by our own choice, we cannot select the antibiotics. We have to just follow a specific group pattern to select the antibiotics for framing the antibiogram. So actually, the group A will consider all the routine primary testing panel for all the bacteria, and group B will be just using the antibiotics for the organisms which are showing resistance to the agents for the primary panel. Similarly, group C will have certain alternative or supplemental antimicrobial agents for testing, and group U antibiotics are specifically for the isolates which has been isolated from the urine samples of patients suffering with urinary tract infections. And group O is, again, it is based on the clinical indication of the patient, and normally these antibiotics are not in the routine testing and reporting in the United States. And few antibiotics are also in the investigational group. This again, it is not in United States, but we still follow or choose the antibiotics for our antibiogram patterns. So this is actually a model chart of the table 1, what I was talking about. Here you can see group A showing the routine primary panel. From here, you have to choose the antibiogram based on the group of the isolate which has been isolated from the clinical samples. And if you see any resistant pattern for these preliminary antibiotics, you can immediately choose the group antibiotics from the group B. So similarly, the table continues like group O, U, investigational, like that. So from each group, you have to select few antibiotics for performing the antibiogram test. And after selection, the test, after performing the antibiogram, the CLSA guidelines also shows us the interpretative criteria based on the MIC breakpoints of based on the measurement of the zone diameters, and it is categorizing the organisms into 5 different groups like susceptible, dose dependent, intermediate, resistant, and again finally the non-susceptible ones. And sometimes the bacteriologist or the microbiologist will haphazardly choose the antibiotics. They will perform the test and they will report to the clinicians. And the clinicians also will prescribe the patients based on the antibiogram profile which was given from a bacteriology lab. But the guidelines says you a warning, like the antibiotic which has been selected may be active in vitro, but it will not be effective clinically. So it has to be empirically selected based on the clinical improvement of the patients, especially in case of enterococci, the use of cotrimoxazole. It will be actually effective in vitro, but it will not be clinically effective. So these sorts of warning signs are also given in the guidelines, which has to be followed for each and every organism or an isolate that has been isolated from a patient sample. And we have to be also very careful with the repeat isolates from the inpatients, those who are in ICUs or long stay or long hospital stay, because it states that the isolates will be initially susceptible, but as time progresses, it may become intermediate or resistant once the therapy is initiated. So we have to be very careful with the antibiogram pattern in observing the AMR surveillance data. And the guideline also says what are the tests to be carried out. This also, so many labs or so many hospitals or even the standard reputed organizations, they do not follow properly. And this is actually the basic routine. Our gold standard Kirby-Boyer method, the disk diffusion method, which is done on a Muller-Hinton agar plate. And here the zone interpretative criteria, and it is so worrisome because I myself have observed few labs just measuring the radius of the zone to give the susceptibility zones, which is highly wrong. Actually, we have to measure the entire diameter of the zone of clearance, and it has to be compared with the interpretative breakpoint criteria. So this is one mistake where the normal healthcare professional do in the routine laboratory. And once that test is done, if we just suspect any resistant strains, definitely we must enter into certain supplemental tests which may be either required or optional. Say for example, we have certain clindamycin resistance for your staphylococci, then beta lactamase producers again for the staphylococci, then we have ESBL producers, carbapenemase producers like colistin resistant strains. So these tests has to be followed based on these guidelines, where the guideline will indicate you the test description, and again it will also be specifically located in different tables. So these tables have to be definitely referred for the methodology of how to perform the test and also to interpret the results again. Then sometimes an additional screening test which will also be involved. Say for example, in case of your enterococci, suppose if we suspect, if we screen, if it is positive for the vancomycin resistance, then we have to enter into certain confirmatory tests. Normally these confirmatory tests are now not done in or not performed in various laboratories. So it has to be done on a mandatory note. Then we also have surrogate antigen agent test. So sometimes, say for example, if you don't have a certain disc, say for example, so here you can see ceflaco, cefdinirin. So sometimes these drugs, these discs may not be available. So in this case, you can just use a surrogate agents like cefazolin, which will give you the same zone interpretative criteria in terms or in place of these antibiotics. So these you can just use an alternative agent to identify the antibiogram susceptibility or resistant pattern. Similarly, you can use for methicillin resistance, you can proceed with cefoxitin, and again for the penicillin resistance, you can just go in for the oxacillin. So like that, we have surrogate agents, but I do not know how many microbiologists will know all these facts. So in place of these drugs, you can just go in for an alternative agent, and again you have specific locations of the tables where you can just go and identify, perform the test, and record the antibiogram for the AMR surveillance data. We also have certain equivalent agent test, which is also given in the guidelines, and in the guidelines it will be provided with a term or. So say for example, cefotaxime or ceftriaxone. Similarly, colistin or polymyxin B. So for the colistin resistance, instead of using the drug disc colistin, we can just go in for polymyxin B, which is very efficient in producing the same zone of inhibition or the same interpretative criteria. So these 5 tests has to be mandatorily done, or wherever necessary, it has to be definitely performed to record the AMR surveillance data. So this is one example. After giving the list of all the 5 tests and of how to perform all these tests, the CLSC guidelines just enter into different groups of bacteria. Actually, the guideline starts with a family of Enterobacteriaceae. So if you take the first group, Enterobacteriaceae, the initial part of the guideline, will always talk about the culture medium or the culture conditions of what it has to be selected, how it has to be performed, the incubation conditions, all those details will be there. So you have to follow it. And again, the selection of antibiotics. So as I have already mentioned, you can see the groups here. So from each and every group, you have to select one antibiotic discs for performing the antibiogram pattern. So here you can see the penicillin. Then we have the beta-lactam combinations. So we have so many combinations like this. And in Saveetha, actually, apart from these combinations, you can also have certain updated combinations. We use cephalosporin sulfabactam. Actually, in recent days, we are getting resistance for that particular antibiotic as well. And also in case of cephalosporins, we know we have different generation of cephalosporins. We can, for the gram-negative Enterobacteriaceae being gram-negative, you can just choose antibiotics from the 3rd generation antibiotic. And if it is a Pseudomonas, you can go in for 4th generation cephalosporin group of antibiotics. So like this, you have to be selectively choose the antibiotic, and you can also perform and follow an SOP for based on your particular lab feasibility. So similarly, you can just select one antibiotic from each and every group of the antibiotic and perform the Kirby-Boyer method to record the zone interpretative criteria. So after Enterobacteriaceae, the guideline just continues for each and every priority pathogen as recorded by the WHO. You can just see the immediate pathogen will be the predominant nosocomial pathogen, the Pseudomonas aeruginosa. Then the table 2B talks about the very vital, the priority drug-resistant bacteria called Acinetobacter. So like this, the table continues for each and every group of bacteria. So you have to select appropriate antibiotic for the appropriate organism panel from these guidelines and from these tables. And again, 2J is very important because it deals with the anaerobic bacteria, the antibiotics that has to be selected, the culture conditions that has to be followed for performing the antibiogram to record the AMR surveillance data. So again, after Enterobacteriaceae, you can also go in for the Staphylococcus, which is a very vital gram-positive cocci involved with septicemic conditions and skin and wound infections in hospital setup. And MRSA, we all know. So again, we have certain very important guidelines, MIC breakpoints, how to perform the cefoxitin disc diffusion, the oxacillin MIC. So many parameters, all these parameters have to be definitely followed by any microbiologist in a microbiology lab to report a perfect antibiogram profile. So these are the antibiogram groups which can be selected for the staphylococci. And it again, the table again, the guidelines goes on like this. It will detect the methicillin resistance, the vancomycin agar screening. Then again, you can go in for the clindamycin resistance, HLAR strains, like that it goes on. So for all the resistant strains, these guidelines or these methodologies can be followed as of the standard guidelines. Then after performing all those, or after that screening, this is actually a very important and vital screening for the ESBL detections. So here we could see that even the research scholars who are working on the ESBL strains, what they'll do, they'll just refer the previous year papers or previous articles, and whatever they have reported, those particular authors have reported, they will just perform the same test, they will perform in the same manner, and actually the results will be totally insignificant. So I suggest the research scholars to follow. Say, for example, if you're working on ESBLs, please go refer to table 3A, which exclusively talks about the antibiogram pattern for the extended spectrum beta-lactamase producing Klebsiella, E. coli, Proteus. Here you can see the disc diffusion parameters of what the dose of the disc has to be taken and how it has to be interpreted. So this is actually a very, very vital table which is given in the guideline. So like this, we have each and every, for every resistance strain, say for this is actually the test for the carbapinamases. So it comes with a picture as well. So based on the colors, you have the interpretative criteria. You can just say whether the strains are producing carbapinamases and it is resistant to the particular group of drugs. Similarly, we have modified carbapenem inactivation methods, the zone, how it has to be observed, everything it is clearly given with a pictorial representation. And even for the metallo-beta-lactamases, so the last figure, you can see the metallo-beta-lactamases, which is a very vital resistant trait now emerging in various communities. This is again colistin resistance, which is very recently it is becoming a trend in case of Pseudomonas aeruginosa. So the colistin resistance, how it has to be performed, how it has to be interpreted, everything is given in a detailed manner. So you have to be definitely follow all these guidelines. This is one important detection method for the beta-lactamase production in Staphylococcus. Actually, here, most of the technical staff, if you see a zone, immediately they will write, yeah, it is a positive producer for beta-lactamase. But here itself, you can mention, it is mentioned that a fuzzy or a beach-like zone, it is actually negative, and a clear zone like a cliff like this. Only if you see a zone like this, then you can go in for the positive penicillin disc. But if the technical staff or the microbiologist is not trained properly, then here the interpretation will be wrong. So these sort of technical details or technical aspects have to be really followed based on the guidelines. And periodically, definitely, we know that for any baseline surveillance data, we have to be have a quality check process. For that also, the guideline has its own quality check table where you have to select the disk content. You can go in with the standard organisms. You can just follow the test again. You can perform the test and you can just compare the zone and you can just check whether your lab is performing properly in accordance with these tables. So these are some of the quality check tables and the ranges. And the frequency also, it varies. Actually, in Saveetha, we actually conduct the test once in 3 months for the as a QC frequency. And these troubleshooting points have to be considered while you frame the perfect antibiogram in order to give a perfect AMR surveillance baseline data. And this guideline, it's very interesting to note because nowadays we are getting everything on a commercial note, the discs, everything we are procuring from standard companies, pharma companies. But the guidelines, this guideline also provides the details. Suppose if you are going to produce your own disc, so that again, how to prepare the stock solutions, in which solvent it has to be dissolved, in which diluent it has to be diluted, how it has to be done, all the details are given here. So normally, most of the researchers, they follow their own dilution pattern, they would solvent they will select, but it is not like that. You have to exactly follow the proper guideline, proper standard methodologies have to be applied in the form of SOP in all the microbiology laboratory. Only then we can get a proper AMR surveillance data. So the overview of this cumulative antibiogram is also being given by the WHO, actually in order to avoid any misleading data. Again, the cumulative antibiogram has to be statistically significant. So this significance will definitely rely only, this statistical significance can be only achieved only if your antibiogram pattern or the antibiogram is performed in a proper or a perfect manner based on all the guidelines, whatever I have been talking so far. So that is very, very important. So based on the antibiogram, immediately you can just go and take the data. You can just check whether the organism is multi-drug resistant or extensively drug resistant or pan-drug resistance. You can just provide the AMR surveillance data to your infection committee group or to any of the higher authorities, and you can just alert the higher authorities regarding the emergence or the prevalence of the drug resistance strain in that particular hospital setup. For this, definitely a knowledgeable person from a microbiology laboratory to collate and interpret the raw data is very, very essential, because only she or he can summarize and present the data in a perfect manner, and she or he has to be updated often about these guidelines, and he or she has to track the records and the reports, or they have to maintain a proper training process or a refresher courses to make a proper antibiogram, and in making an accurate daily reporting of the antibiotic susceptibility profiles. And the microbiologists also play a vital role in formulating the empiric hospital policy, translating the cumulative antibiogram into the practical applications. Thus, this antibiogram has so many advantages, because our main idea, goal or aim is to monitor the resistant trends and to compare the susceptibility rates between the institution to make a formulary decision making. And we can also inform the local and the institutions so that they can recommend the selection of the empiric therapy in the antibiotic stewardship policy, which is following. But it also has a certain disadvantage, because if they don't have a sufficient microbiology laboratory support, then definitely this perfect antibiogram would be of doubtful, and again a proper AMR surveillance data will also be on a doubtful note. And in a short term, for a short term antimicrobial stewardship program, these antibiograms are not a reliable metric also, that is also there. And when this AMR surveillance data has to be presented in a very, very palatable format for the higher authorities, because this sort of guidelines or this sort of presentation will not be very much interpreted by the higher authority. So it has to be detailed when you're presenting or documenting to a particular group, or on a state level or on a regional level or on a national level. You must definitely give all the data of how the antibiogram has been performed. So this is one of my own paper which is published in the year 2018. So here you can just see, I have mentioned the groups, the antimicrobial agents which has been selected. It also shows you the disk content, then the zone interpretative criteria, and also the susceptibility pattern, the number of isolates with the percentage. A similar sort of paper which was published in from South Africa, it shows a comparative statement of 3 years resistant and susceptibility profile. Here in the same column, you can see the methicillin sensitive and methicillin resistant. So it is given in a very, very palatable form that any person who is reading this data will come across or will know what is happening in that particular healthcare setup. And this is again one sort of representation where you can just group the antibiotics, and for each antibiotic group you can just mention about the percentages of the resistant traits that is prevailing. Otherwise, you can also take individual antibiotics and the resistant numbers in terms of percentage. So these are different patterns of presentation which can be used for the documentation purpose. These are actually the mandatory process to be known by everyone to present an AMR surveillance baseline data. So ICMR in recent days, it is really concerned with the drug resistant traits among the hospital settings. So it is just implementing so many programs and surveys, and it also, as we are now involving the scientific advancements, definitely this antibiogram surveillance also involves various softwares. So we are just incorporating data sciences where we can just use the different softwares for the analyzing or for comparing the drug resistant profiles among the institutions or among the states or among the countries. So like that. So this WHO net is one of the antibiogram software where all the antibiogram profiles are just recorded or entered. So anywhere from any part of the world, they can just, it is actually a freely downloadable software. You can just download it and you can just compare the antibiogram pattern, resistant profiles, susceptibility profiles of any particular organism that is prevalent in different parts of the country. So this is one of the very vital antibiogram software. This is one such DRI index, which is commonly referred as a resistance map. It is actually introduced in India. It is actually an interactive collection of charts and maps, which summarizes the use of antimicrobials and again the resistant data worldwide. This is again a very easy to use software, and it also incorporates certain formulas and equations so that you can just calculate the drug resistant index between different countries. And GLASS is again one more surveillance system, that is Global Antimicrobial Resistance Surveillance System. It is actually a 5-year program. So every 5 years it changes. And because of COVID, I think it has stopped by 2009. And this year they are just trying to revamp it for the next 5 years. So it is again a supportive documentation for the antimicrobial resistance, which involves the national action plans of many countries. So this is again a very vital surveillance software system. And these systems normally are very helpful in observing the outbreak analysis by forming clusters. So in the year 2018, Huang et al., he conducted a outbreak analysis by forming clusters, and he actually observed 59 clusters of multi-drug resistant nosocomial pathogens, which could be involved in an outbreak. But with the existing manual data or some other basic data, we could identify only 3 outbreaks. So this shows the importance of the software or the software system or the involvement of data sciences, where we can immediately understand or observe the clusters which can trigger an outbreak. And we are proud to introduce this exclusive software at Saveetha Dental College and Hospitals. This is called as DIAS, and this is Dental Information Archiving software. And in our medical college, again, we have Medical Information Archiving software. Here again, we have 2 patterns of entries, one for the patient, like how a commercial lab will give, you can just give the report for the patients. But on the other side, for us, for the surveillance data, we have exclusively different software where the susceptibility and the resistance pattern can be entered, and periodically the data can be obtained from the system. So once these basic guidelines are followed in framing the antibiogram, then again you can just incorporate the advanced software system. Definitely the WHO finally recommends a final audit structure and process, so that the final antibiogram pattern, before giving you the AMR surveillance data, it has to be audited properly, then it has to be critically reviewed based on the patient's record, it has to be compiled and analyzed properly, and final presentation has to be made to the hospital infection control committee and to the treating physician. Only then it can immediately follow the standard treatment. It can enter into the standard treatment guidelines, which finally leads up to your antimicrobial stewardship policy in picking up the empiric therapy and by understanding the local antibiotic resistance trends. And in case of antibiotic stewardship policy, our CDC really worries, because more than half of the antibiotic prescribed for certain selective events in hospital was not consistent with the recommended prescribing practices because of the clinicians, and antibiotic prescribing was not supported in different groups. Say, for example, in case of community acquired pneumonia, urinary tract infections, it is not followed properly. So this was a common complaint which was given recently in the year 2019 by the CDC. And so the CDC has framed a core element has to be followed in the antibiotic stewardship policy, where first the leadership commitment must be there, who will take accountability, and they must also have an expertise on the different drugs. They must actively oversight these changes, these antibiogram pattern or the emerging resistance trends. They must track it, they must report it, and finally they must also educate all the healthcare professionals. So these are considered as the core elements of a antibiotic stewardship policy. And this core elements, actually it is mainly framed to in the version of an interdisciplinary approach. It is not involving one particular committee or a microbiologist or a particular person as such. It is an interdisciplinary approach involving so many different committees that are coming under the healthcare setup, especially with a goal to enhance the infection prevention and the control. And also they must be able to prescribe proper antibiotics, appropriate antibiotics and their dosages with the proper durations. They have to reassess the treatment policy, and they must also support the surveillance of the AMR and hospital-acquired infections. And finally, they must educate their staff periodically so that a proper policy can be made towards an empirical therapy. So there are three intervention categories in the ASP. We have a broad therapy, broad intervention category where it particularly involves the antibiotics, proper prior authorization or audit and feedback. Then the second, the pharmacy plays actually a vital role in case of your antibiotic stewardship policy, like how in the antibiogram and AMR surveillance, a microbiologist will play a vital role, but here in the ASP, the pharmacy will be playing a vital role, and again the clinicians, who have to be very careful in giving treatment based on the syndrome specific manner, because CDC consider many clinicians are treating the patients with indiscriminate antibiotics, say for example in case of non-infectious fever, non-infectious etiologies of leukocytosis, and again syndromes with potential antibiotic overuses in case of catheter-associated UTI, asymptomatic bacteria, so on. And also in case of the viral infections, they are treating the patients with the antibiotics, or they can just treat a bacterial infection and not colonization. So many basic errors are also made on the clinician side. So CDC warns the clinicians so that a proper empirical therapy is being followed among the patients of their hospitals. So it is the interlinked program between a microbiologist, a clinician, and a pharmacist to apply the general principles of the antibiotic stewardship policy, because we have to be accurately identify the patients who need proper antibiotic therapy, and you must avoid the agents with overlapping activity, and we must monitor for toxicity, optimizes the dose, etc. So we have to be very careful with the inpatients with the 5 Ds. Say, for example, you have to properly diagnose, properly treat them with appropriate drug, with appropriate doses, appropriate duration has to be followed, and we must be very careful the problem is not escalating. And again, the clinician have to play a vital role in outpatient antibiotic stewardship policy also with the commitment, because when the patient comes and leaves the clinic, because it is their responsibility, the clinician's responsibility to make that outpatient doesn't transmit any resistant strains from the hospital system to the community. So that policy is also being given by the CDC and also by the WHO bodies. Even in the nursing setup, we have to be very careful. The nurses are also being trained, and core elements of the antibiotic stewardship program is also being given for the nursing homes. So there are guidelines for them also. So we have to educate the nursing staff, the clinicians, the residents, and again the families about the antibiotic resistance, and to give them the opportunity to improve the use of antibiotics. And once this regional level or a local level stewardship program is achieved, now the pharmacists enter and they play a vital role in making the policy on a national level. So in a national level, they can just achieve in three different categories: a basic category, which requires only a limited resource, and an intermediate category, which will require some planning and dedicated staff to implement the diagnostic stewardship among the different states of the nation. And there are also certain advanced categories where this is actually very important, because they will be enforcing certain policies requiring the prescriptions, and definitely the clinicians must follow the same. And again, to follow the same, they must definitely follow the proper antibiogram pattern. That is actually the basic baseline for the AMR surveillance. So this table, as recommended by the CDC, it gives us the selected stewardship activities and the requirements that has to be definitely implemented in a hospital setup. So it has certain training on the guidelines. This has to be followed as a policy. Then the antibiotic rounds has to be held on regular basis for review and choices of selection. Then the prescription alerts must also be done to the clinicians in order to avoid overlapping or duplicative. And this auditing is very, very important to get the feedback based on the patient's medical record, and prior authorization must be there for the clinician to implement the antibiotics on a patient, and antibiotic restrictions must also be there where a blanket rule is followed for the clinician. And again, there must also be an automatic stop order in case of any errors, and again automatic changes, because the prescription can be changed and the clinician must be able to take that change immediately without any doubt. And there must be again a selective lab reporting is very, very vital, which involves a bacteriology laboratory, and a cascade of lab reporting has to be reviewed and auditing so that it will assist in the formulation of the empiric therapy in the stewardship policy. And antibiotic timeout has to be defined, and regular prompts has to be re-evaluated with antibiotic reminder, and facility level of antibiograms has to be there in order to implement a proper stewardship policy in any hospital environment. So with this note, as we are progressing, as I have already mentioned, as we are progressing to the World Antibiotic Awareness Week, now it is the need of the hour to implement both the hospital antibiogram pattern of the AMR surveillance baseline data and antibiotic stewardship policy to be steered as of standards. So thank you all for your patient listening.